cardiac output is the amount of blood heart pumps through the circulatory system in a minute. The amount of blood put out by the left ventricle of the heart in one contraction is called the stroke volume. The stroke volume and the heart rate determines the cardiac output. The cardiac output is expressed in two forms, the stroke volume and the minute volume, unit per liter or ml per minute. The volume of blood ejected by the left ventricle during a heartbeat is called a stroke volume, and the volume of blood ejected by the left ventricle in each minute is cardiac output, which is equal to the heart rate multiplied by the stroke volume and therefore is measured in liters per minute. The normal range of cardiac output is 4 to 8 liters per minute but can vary depending on the body's metabolic needs. Here, few terms are needed to be elaborated before going further into details. These terms are very important to understand the future part of the lecture. One is the end diastolic volume, which is the amount of the blood that is in the ventricles just before the heart contracts. Doctors use end diastolic volume to estimate the heart's preload volume and to calculate the stroke volume and ejection fraction. Now, ejection fraction is a measurement expressed as a percentage of how much blood the left ventricle pumps out with each contraction. The ejection fraction of 65% means that 65% of total amount of blood in the left ventricle is pushed out with each heartbeat. Pulse pressure is the difference between systolic and diastolic blood pressure. It is measured in millimeters of mercury and it represents the force that heart generates each time it contracts. While resting blood pressure is normally approximately 120 by 80 millimeters of mercury, which yields a pulse pressure of approximately 40 millimeters of mercury. The normal range of pulse pressure is between 40 and 60 millimeters of mercury. Pulse pressure tends to increase after the age of 50. This is due to stiffening of the arteries and blood vessels as one ages. Now, central venous pressure is the blood pressure that will occur near the right atrium of the heart. And the central venous pressure reflects the amount of blood returning to the heart and ability of the heart to pump the blood back into the arterial system. Total peripheral resistance refers to the amount of force affecting resistance to the blood flow throughout the circulatory system. While preload, also known as left ventricular end diastolic pressure, is the amount of ventricular stretch at the end of the diastole. Think of it as heart loading up for the next big squeeze for the ventricles during systole. Afterload is the pressure against which the heart muscle must work to eject blood during systole, or systolic pressure can be said as that. The lower afterload, the more blood heart will eject with each contraction. Like contractility, changes in afterload will raise or lower the Starling curve related to stroke volume index to left atrial pressure. Cardiac index is the calculation of the cardiac output divided by the person's body surface area. Now, cardiac output is controlled and affected by many different factors, including the atrial and ventricular reflexes, the autonomic nervous system, hormones, and the blood ion concentrations, emotions, intravascular blood volume, or resistance of the blood vessel to the blood flow. The more resistance given to the blood flow, the lesser will be the cardiac output. But it can be due to loss in elasticity of the blood vessels and atherosclerotic changes or any other blood vessel pathology. The size of the heart, like in case of dilated cardiomyopathy or hypertrophy of the heart, the heart cardiac output decreases because the heart muscles are themselves weakened to push more blood in anomalies like in cardiomyopathies. But in left ventricular hypertrophy, the size of the ventricular muscle has increased to such an extent that it causes a reduction of the internal volume of the ventricle because hypertrophied heart muscle cannot expand enough to allow fulfilling of the ventricles, which reduces the blood filling during the relaxation phase. So even the heart muscle has gone big, but it still is not filled with enough blood which it can throw outwards during contraction. Cardiac anomaly like inflammation of the pericardium or restrictive heart pathology, here the cardiac output can also decrease because pericardium is not allowing the ventricles to expand enough while relaxing, so resultant filling of the ventricles is reduced, which causes a decrease resultant outpush to the flow of the blood during the preceding contraction, causing lesser cardiac output. Even in case of very fast heart rate like in tachycardia, where the heartbeat has gone way above 100 or 150 plus or 180, heart is not getting enough time to relax to fill up before another contraction, so the resultant outthrow of volume of blood by ventricles reduces. In case of obstructive cardiomyopathy like any tumor or swelling in the heart structures like hypertrophic obstructive cardiomyopathy, the outflow of the blood through the ventricles is physically hampered and impeded, leading to lesser cardiac output. In cases of myocardic infarction or cardiac myositis, or the inflammation of the cardiac myocardium, or any endocarditis can easily cause a decrease in cardiac output as well. Secondary factors include extracellular fluidine concentration, like any imbalance in sodium or potassium concentration can cause disturbances in the heart rate and the stroke volume. Body temperature, emotions such as excitement or anxiety can disturb cardiac output. Sex of the patient or age of the patient are also the considering factors. Now, the normal output is different for different people depending on the size. Usually, adult heart pumps about 5 liters of blood per minute at rest, but when you run or exercise, your heart may pump 3 to 4 times that much to make sure your body gets enough oxygen and fuel. The stroke volume for each ventricle are generally equal, but being approximately 70 milliliters in a healthy 70 kg man. Men on average have higher stroke volumes than women due to larger size of heart, but females have higher rate of beating of the heart. Stroke volume is the volume of blood pumped out of each ventricle per beat or contraction. As the stroke volume increases, the cardiac output also increases. Stroke volume depends upon end diastolic volume and contractility. So, stroke volume is equals to end diastolic volume minus the end systolic volume. Whereas the cardiac output is stroke volume into the heart rate, which will be calculated as millimeters per minute divided by millimeter per beat per minute. The average rate is 70 beats per minute. Average stroke volume is 70 to 80 milliliters per beat. Average cardiac output is 5000 ml per minute. Cardiac output varies widely with the level of activity of the body. Now we have to discuss a bit about the regulation of the heart rate and the stroke volume, and which relates to the cardiac output. Factors that regulate the cardiac output is by changing heart rate and stroke volume. Primary factors include blood volume reflexes, autonomic innervation and hormones. Secondary factors include extracellular fluidine concentration, body temperature, emotion, sex of the patient and the age of the patient. Now the blood volume reflexes are there to be discussed with primary factors. Two heart reflexes respond to change in blood volume, the atrial reflex and the ventricular reflex. The atrial reflex affects the heart rate via the atrial vein bridge reflex. The atrial reflex, also referred to as right heart reflex or vein bridge reflex, is triggered by the increase in the venous return to the heart. Baroreceptors in the superior and inferior vena cava sense pressure changes and send impulses to the sinoatrial node, increasing the heart rate. Now in ventricular reflex, whereas the atrial reflex affects the heart rate, the ventricular reflex affects the stroke volume. The amount of blood ejected is dependent on the amount of blood filling the ventricles during diastole, during the relaxation phase, called the end diastolic volume, and the amount of blood left in the ventricle after the systole, which is the end systolic volume, which is the amount of blood left in the ventricles after it has pushed the blood forward. Now, regulation of the stroke volume is done by few variables such as end diastolic volume, volume of the blood in the ventricle at the end of diastole, sometimes also called as preload. Stroke volume increases with increased end diastolic volume. Total peripheral resistance is the frictional resistance in the arteries and inversely related to the stroke volume, also called the afterload. The contractility depends on the strength of ventricular contraction. Stroke volume increases with contractility. Ejection fraction is the percentage of end diastolic volume that is ejected per cardiac cycle. Stroke volume is also equal to end diastolic volume minus the end systolic volume, or SV divided by EDV multiplied by 100. In normal, ejection fraction is normally about 50 to 65%. In a diseased heart, it may even fall down to 30 to 35% at the point where we have to decide to put them in the pacemaker or not. Now let's give a bit of a view on Frank's Starling law. That is when the blood in the ventricle increases, the cardiac muscle fibers stretch and then contract. The amount of blood in the ventricles is the amount of stretching, and the force of contraction are directly proportional. An increase in the blood volume results in great fiber stretching, and then a more powerful contraction results due to this stretching. The relationship is referred to as Frank's Starling law. The action of the cardiac muscle fiber is analogous to a rubber band. Stretching a rubber band longer results in a more forceful snap when it is released. Now, in venous return, the end diastolic volume is controlled by the factors of like total blood volume in the circulation, venous pressure, which is the driving force of the blood return. Veins have high compliance, that means they have a large capacity to store a greater amount of blood. They stretch more at a given pressure than arteries. Veins also have a thinner wall. And veins are also, like being a capacitance vessel, carry 2/3 of the blood volume in the vein. They hold more blood than arteries but maintain the lower pressure. Factors that determine the venous return is pressure difference between arteries and veins, which is about 10 millimeters of mercury. Or can also be said as pressure difference between the venous system, such as highest pressure in the venules, lowest pressure in the vena cava into the right atrium. Sympathetic nerve activity is there to stimulate smooth muscle contraction and lower the compliance. Pressure difference between abdominal and thoracic cavity during respiration also is one of the factors in the venous return. Now, as the cardiac output is made up of heart rate and stroke volume, at rest these are relatively constant. With exercise, the heart beats faster, more blood is pumped out with each heartbeat, contributing to the rise in blood pressure. Changes in volume of blood with cardiovascular system will also affect the blood pressure. Like if there is too much volume, systolic pressure may rise. If there is too less volume, such as a person when he is severely dehydrated or has lost a large quantity of blood through a wound, there would be less blood for the heart to pump, thereby reducing the cardiac output and BP. Initially, the heart beating rate will increase to compensate for the loss of volume of blood in circulation, but when it is not able to keep up over the amount of blood volume, the cardiac output then decreases. For a typical fit young person, the cardiac output might go up to 20 liters per minute at the peak of the exercise. For world-class athlete in an endurance sport, the maximum cardiac output might be 35 liters per minute. Now, how we can say the nervous system affects the heart rate is via the autonomic nervous system. Although the heart rate is established by the sinoatrial node cells, it can be affected by the autonomic nervous system. Changing heart rate is the body's principal short-term mechanism of controlling cardiac output and blood pressure. When the stroke volume decreases, the body attempts to maintain adequate cardiac output by increasing the rate or the strength of the cardiac contraction. The most important control of heart rate and strength of the contraction is autonomic innervation. There are two centers, cardio-acceleratory center and cardio-inhibitory center, that control this particular portion. The medulla oblongata is located in the brain and includes a cluster of neurons that make up the cardio-acceleratory center, and sympathetic fibers that begin in the cardio-acceleratory center innervate the sinoatrial node, the AV node, and the parts of the myocardium. Cardiac acceleratory center stimulation causes these fibers to release norepinephrine, thereby increasing heart rate and contraction strength. While in cardiac inhibitory center, the medulla oblongata also contains the opposing cardio-inhibitory center reflex, which is parasympathetic effect. Now, the parasympathetic fibers that begin in the cardio-inhibitory center also innervate the sinoatrial node and the AV node. The cardio-inhibitory center stimulation results in the transmission of nerve impulses along the parasympathetic fibers and release of acetylcholine, which decreases the heart rate. Now, in hormonal regulation of the cardiac output, three particular hormones are very important: norepinephrine, epinephrine, and acetylcholine. And here, the norepinephrine, epinephrine, and acetylcholine are released, when they are released, the force of myocardial contraction is altered, thus affecting the stroke volume. Norepinephrine and epinephrine, in response to sympathetic stimulation, causes the norepinephrine release in the myocardium, and norepinephrine and epinephrine are also released by the adrenal medulla. Norepinephrine increases heart rate and myocardial contractility. Epinephrine excites the sinoatrial node, thereby increasing the rate and strength of the myocardial contraction. In clinical correlations such as fight or flight response, it is a physiological response during danger or stress. During this automatic involuntary response, norepinephrine is released by the medulla oblongata, and norepinephrine and epinephrine are released by the adrenal glands, resulting in faster heart rate and more forceful contraction of the heart. Additional effect of the fight and flight response include an increase in respiration rate, shunting of the blood away from the digestive tract and towards the muscles, limbs, and release of the blood sugar, dilatation of the pupils, decreased sensitivity to pain. Flight or fight response protects the humans from dangers faced in physical environment, for example, encountering an adversary, and prepares the body to fight the threat or flee from it. In parasympathetic stimulation results in release in acetylcholine, which inhibits the heart activity by decreasing the force of contraction. In the secondary factors which we have discussed already, like extracellular fluid ion concentration, it has a particular effect, like elevated levels of extracellular potassium or sodium ions can decrease heart rate and stroke volume. Abnormal potassium levels interfere with the sinoatrial node, affecting the heart rate. Too much potassium causes cardiac contraction to become weak and irregular. Too little potassium decreases the heart rate. High concentration of sodium interferes with the calcium activity in the muscle contraction, reducing contractility. Calcium ion concentration has also its effect, like abnormal calcium ion concentration affects the strength and duration of the cardiac contraction, which then affects the stroke volume. High calcium levels cause long and lengthy contractions. Low calcium level weakens the contraction. And temperature and emotions are also having their particular effect, like changes in body temperature can affect the heart rate and contractility, with increased body temperature resulting in increased heart rate. Decreased body temperature slows the heart rate and results in less powerful contractions. Strong emotions such as anger, fear, and anxiety tend to increase the heart rate, making you feel like your heart is pounding. Other mental states include depression and grief, and probably stimulate the cardio-inhibitory center, resulting in slowing the heart rate. When we discuss about the sex and the age of the patient, the sex and age are a contributing factor in deciding the heart rate and heart pumping. Here we have to say the female heartbeat is generally faster than that of males, but the amount of blood pumped by the heart in one particular cycle is more in men than in the females. Physiological variations of cardiac output is cardiac output is more in adults than in children because of blood volume is more. Cardiac output is more in males than in females. Cardiac output increases at high altitude places. Cardiac output increases during pregnancy because of increased body blood volume. Cardiac output also increases during exercise, and the cardiac output increases during emotional expressions. The cardiac output is done by a few methods. One is the Fick principle, the dilution method is right heart thermodilution, Doppler ultrasound method, and the impedance cardiograph. Echocardiogram is also one of the techniques in calculating the cardiac output. This uses the sound waves to make an image of your heart and blood flow through your heart. Measuring the cardiac output is straightforward and relies on a few simple concepts which we can review, like left ventricular outflow tract is assumed to be roughly circular and calculate the area of the circle. Pulse wave Doppler through the same point in the center of the left ventricular outflow tract tells how far the blood is traveling at any time. The area under the curve tells us how far the column of the blood has been pushed. Y-axis is in meters per second and x-axis is in seconds, so the area under the curve will tell how far the blood has moved at particular velocities for the amount of time. We work out the volume of cylinder, that is multiply the area of left ventricular outflow tract, that is the circle, by the length of the blood travels. You get the stroke volume, that is volume injected per beat. The stroke volume multiplied by heart rate gives us the cardiac output. Divide the cardiac output by the body surface area, we get the cardiac index. The arterial pulse waveform analysis is used to calculate the cardiac output from the shock waves created by the blood flow. Cardiac output is calculated as oxygen consumption divided by a difference in the oxygen saturation of the arteries in the veins, which is taken in milliliters of the oxygen. Thank you. Do like and subscribe if you like it. Thanks a lot.